Hi, my name is Michaela Morris, and I'll be presenting today on Marfan syndrome. Marfan syndrome is a disorder that affects the body's connective tissue. It's an inherited autosomal dominant disease, which is characterized by the loss of elastic tissue that affects many body systems, including neurological, respiratory, cardiac, musculoskeletal, nervous system, skin, and lungs. So a little bit of history regarding Marfan syndrome. It was named after a French pediatrician back in 1902, but it started back in 1896, where he described a hereditary disorder of connective tissue in a 5-year-old girl who had disproportionately long limbs. But it turned out that this girl probably didn't even have Marfan syndrome, and it's really been characterized even after 1902 with the symptoms from other doctors along the way, although it had been named after Antoine Bernard Jean Marfan. Some famous people affected that you guys might recognize is Jonathan Larson, who's a playwright and a composer, and Abraham Lincoln, who was our president. It is assumed that they both had Marfan syndrome. Regarding the prevalence, it affects about 1 in 5,000 people, and it includes men, women, children of all races and ethnic groups equally. But about 3 out of 4 people with Marfan syndrome will inherit it, or 75%, and 1 out of 4 will get a spontaneous mutation. Some people, the ones who maybe the first in the family to get it, it's known as a spontaneous mutation, and there's a 50% chance that Marfan syndrome will be passed along the genetic mutation each time they have a child. And about 200,000 Americans are affected. This looks like a lot, but there's multiple different areas that are affected in the body with Marfan syndrome, and each person is affected differently. And that's called variable expression, and features can vary often among the people, even in the same family who have the same condition. So we'll go head to toe here just so we can explain it a little bit better. Under HENT, so people's eyes with Marfan syndrome, they might have lens dislocation or ectopia lentis. They can also have retinal detachment, cataracts, glaucoma, nearsightedness or myopia, oropharynx, which is a high palate, and crowded dentition. They may also have neurological stuff affected, such as dural ectasia, which is an enlargement in the dural sac. That's seen in about 60 to 80% of people with Marfan syndrome, which is a lot higher than the normal population. Cardiac-wise, it's probably the most significant and most dangerous amongst this group, but you'll see mitral valve prolapse, aortic root dilation, aortic dissection from that, and heart murmurs. The mitral valve prolapse can also occur, and that's in 60 to 80% of patients, and it worsens with time, and it's complicated by rupture. But the aortic root disease is seen about in 50% of children and 80% of adults, which is a lot higher than the normal population. Pulmonary-wise, you can have a spontaneous pneumothorax, you can have abdominal and inguinal hernias, or stretch marks that are unexplained. Musculoskeletal-wise, you'll see a patient having, with Marfan syndrome, having tall, slender bodies, long fingers and toes, arm spans that are longer than their body in height, reduced elbow extension, unusually flexible joints, a narrow face, scoliosis, sunken or protruding chest, medial displacement of medial malleolus, positive wrist sign, and a positive thumb sign. And positive thumb sign I included in a picture because you can really try that. It's where your distal phalanx protrudes beyond the border of the clenched fist. And there's a picture that shows, and if you do it yourself, you can really see how flexible and how long someone with Marfan syndrome, their joints really are. So regarding the diagnostic criteria, they use the Ghent criteria, which includes a physical exam of 6 organ systems, and they can include genetic testing or family history. But a genetic test can be used to examine for the gene responsible for Marfan syndrome. It's able to detect an error that causes syndrome in like 99% of those affected. However, the test is very expensive and it takes like 3 months for it to complete. So in most cases, a diagnosis of Marfan syndrome will just be made from the physical features and the symptoms of the syndrome. So there's 2 ways it can work. So if you have a family history, then all you need in addition to that to diagnose them with Marfan syndrome is an involvement of 2 organ systems within the major criteria. So for example, on the right I included some major criteria. So you would have to have one of the major ones here, so like it's say enlarged aorta, then 2 other organ systems involved, whether it's like a long thin face, like through musculoskeletal, and like myopia, so they might have some short-sightedness, and that could be appropriate to diagnose someone with Marfan syndrome. However, if you don't have a family history and you're one of those cases spontaneous mutation, you do need to have 2 major criterias of an organ system. So you'd have to have, for example, an enlarged aorta and dural ectasia, because you have the cardiac system and the neurological system, and then you have to have an involvement of a 3rd system. So whether that be, for example, musculoskeletal with loose joints, that could consider someone an appropriate diagnosis for Marfan syndrome. So the genetic mechanisms of Marfan syndrome, it's an inherited autosomal dominant disease or syndrome. It involves the fibrillin 1 or the FBN1 gene, which is on chromosome 15, and that encodes for the glycoprotein fibrillin 1. And it affects both elastic and non-elastic tissues, and there can be more than like 97 different mutations. It's not well understood how the FBN1 gene mutation causes the phenotype, but the proposed mechanisms are that the mutation results in an increase in a protein called transforming growth factor beta, or TGFB. And this causes problems in the connective tissue throughout the body, creating the features and medical problems you see. And here you can see the related disorders that it could be misdiagnosed for. So as an advanced practitioner, it's important to see and make sure you understand all these related disorders so you're not diagnosing someone with something that they might fall under a different category here. Here is a pedigree of the familial inheritance of Marfan syndrome. As you can see, it's autosomal dominant. You can see that it affects both males and females equally, and you have a 50% chance of getting it. Within the medical management side of things, as an APRN, it's important to make sure that your patients have annual echocardiograms if you're considering or they have a diagnosis of Marfan syndrome, as well as ophthalmology exams and aortic ultrasounds. It would be beneficial for your patients to have genetic counseling and address their symptom-based stuff. And in Marfan syndrome, as you get older, you kind of see more things come out. Not many children are diagnosed with Marfan syndrome right off the bat. Usually you kind of see the symptoms in adolescence. And you want to really encourage them to limit their strenuous exercise because of all the cardiac symptoms. So medication management, the big things are to manage is using beta adrenergic blockers. An example of that is propranolol. And this was used in a study versus placebo, and it came back that it's a standard now care for adult patients. And there's not really any data on children, but it found that there's a slower rate of aortic dilation with beta blockers. And that's because you're dilating the blood vessels, and that reduces the blood pressure and the demand on the heart and the afterload. And there's a survival at 10 years that wasn't really significantly improved, but they also did a study with angiotensin receptor blockers, and losartan was approved by the FDA in 1995. Again, like the beta adrenergic blockers, It blocks the action of the angiotensin dilating blood vessels and reduces blood pressure. Recent animal studies, models of the FBN1 mutant demonstrated decreased rate of aortic dilation. So, regarding aortic aneurysms, there's some surgical interventions that you could consider for your patients. People who have these elective repairs have better survival rates. But their recommendations vary among when they should or when they are warranted for the surgical intervention, and that's based off the aortic root diameter. So as you can see, it's either greater than 4.5 or greater than 5 centimeters, or if they have an increase of 0.5 centimeters per year. So that's why the annual echocardiograms and ultrasounds are very important. They do say that an early intervention is indicated in women who are desiring pregnancy. Regarding the ethical, legal, and social issues, there can be prenatal testing done. There's 2 ways it can be done: via amniocentesis, which is at 16 to 18 weeks, or chorionic villus sampling at 10 to 12 weeks. In some cases, the results may be negative for the defective gene, but may have a different genetic mutation that wasn't tested for that can still cause Marfan syndrome. So it can be done, but it's not definite. But people who are planning a pregnancy can do pre-implantation genetic diagnosis, and that's a 12-month process of implanting the genes for both the mom and dad, and they use the unaffected embryos after being created in the laboratory. It's only an option when a person with Marfan syndrome has a Marfan gene mutation and wants to become a parent, and the NHS will fund a couple to have one unaffected child by PG. And here are my references.